Hello again. This is David Abel, and this is the second video that is part of the Flipped Classroom series, Thrombophilias During Pregnancy. Now, in the next two videos, with the help of case presentations, we will expand upon what we learned in the first video. We will also focus on who should receive anticoagulation and what kind of dosing and when to start this anticoagulation. So let's get started. Let's discuss the first case. Your patient is a 29-year-old prima gravida at 9 weeks gestation with a history of a left-sided deep vein thrombosis 2 years prior. She was using oral contraceptives at the time. A thrombophilia workup at the time revealed her to be a heterozygote for the prothrombin gene mutation. Her family history is negative for thromboembolic events. So let's address the first question. Is anticoagulation warranted? The answer is yes, for two reasons. First, she has a low-risk thrombophilia and a history of thrombosis. Second, even if she did not have a thrombophilia, many would vote for anticoagulation because she experienced a clot while on oral contraceptives, and as pregnancy is a similar hyperestrogenic state, she would be at risk just by being pregnant. So, as we said, she is a candidate for anticoagulation. Now let's change it up a bit. What if the patient was found to be a prothrombin gene mutation heterozygote, but instead of experiencing a clot while on oral contraceptives, her DVT occurred after a skiing accident when she was immobile for a prolonged period? Does she still warrant anticoagulation? Well, this is a little bit of a clinical conundrum. One could argue a good case for both sides, noting a low-risk thrombophilia plus a personal history of a clot warrants anticoagulation. Others could say that this is a low-risk thrombophilia and there is an explanation for the clot, and one cannot assume the thrombophilia was the etiology of the clot. This is how I would actually counsel the patient. I would discuss the risks of anticoagulation and let the patient make her own decision. If the patient elected anticoagulation, what would you use, and how would you counsel her about the risks of anticoagulation? Although we are focusing on thrombophilias and not anticoagulation per se, let's briefly review the anticoagulation options and associated risks. Options for anticoagulation during pregnancy primarily include unfractionated heparin and low molecular weight heparin. Warfarin can be used postpartum and is compatible with breastfeeding. In certain clinical scenarios, such as the patient with a mechanical heart valve, we may use warfarin after 12 weeks as it is better than either unfractionated heparin or low molecular weight heparin in reducing the risk of valve thrombosis. The main risks of anticoagulation include bleeding, osteoporosis, and heparin-induced thrombocytopenia, HIT. HIT can manifest as an early form that is self-limited and a late form that is immune-mediated and can be very serious. Advantages of low molecular weight heparin over unfractionated heparin include a lower risk of these complications, as well as less frequent administration and a more predictable response. Now let's go to another case. Your patient is a 33-year-old gravida 4 para-0 with a history of early recurrent pregnancy loss. She has never gotten past 10 weeks gestation in any of her pregnancies. She was tested for thrombophilias and found to be heterozygous for the factor V Leiden mutation. She is desperate to try something to reduce her chance of another miscarriage and increase her chance of a live birth. She does not have a personal history of thrombosis, nor is there a significant family history. How do you counsel her? Now, this is where I think we have come full circle. Initially, early retrospective studies suggested a link between inherited thrombophilias and adverse perinatal outcomes. However, the methodologies were flawed and these associations were overestimated. More recent and better data, including prospective data, has failed to demonstrate an association between inherited thrombophilia and adverse perinatal outcomes. These adverse perinatal outcomes include recurrent losses, stillbirth, preeclampsia, fetal growth restriction, and placental abruption. The bottom line, as I noted in the first video, is that anticoagulation should not be used to prevent an adverse perinatal outcome. Furthermore, it is important to resist thrombophilia screening in this setting. This is particularly true in the case of a stillbirth, when patients want an answer and want to know why, and frankly, so do providers. But say the patient with a term intrauterine fetal demise undergoes screening and is found to be a heterozygote for the factor V lag mutation. We cannot in any way assume this thrombophilia was responsible for her loss. But I think we are a bit reluctant to do nothing, which is part of the problem. And since we feel we have to do something, well, maybe we'll just give her some Lovenox in the next pregnancy. Now, just as an aside, I see many folks on aspirin only with histories of stillbirth or recurrent losses. While it probably does no harm, again, keep in mind there is no data to support the use of aspirin to reduce the risk of an adverse perinatal outcome. Now, I have included 2 articles for you that address thrombophilias and the lack of an association with adverse perinatal outcomes. First is the TIPS study, a recent randomized controlled trial that we will discuss at the annual meeting, and an editorial from one of the leaders in the field, Dr. Ware Branch from Utah. This is a recent publication put out by the Society of Maternal-Fetal Medicine. It lists 5 things providers should not do, and notice what is number 1. Do not perform a thrombophilia evaluation for women with a history of pregnancy loss, growth restriction, preeclampsia, and placental abruption. Let's go to another case. This clinical scenario is perhaps the most common scenario I encounter, and I would imagine it is one that many of you have also encountered. Your 36-year-old Gravida 2 Para 1 is at 10 weeks gestation and presents for her initial prenatal visit. A few months prior, her primary care physician recommended she undergo thrombophilia screening because her sister experienced a deep vein thrombosis in the postpartum period. Your patient was found to be a heterozygote for the prothrombin gene mutation. The family history is otherwise unremarkable. Your patient is very worried about developing a deep vein thrombosis during pregnancy. How do you counsel her? Well, the first question to answer is it a low or high risk thrombophilia? As we've discussed before, it is a low risk thrombophilia. Second question, is there a family history? And if so, how significant? Now, for me, a significant family history might mean multiple family members who experienced clots, particularly at younger ages, indicating to me that the condition is highly penetrant for this family. Now, the definition of a strong family history is somewhat subjective. Of course, there is a family history because that's the reason the patient was tested in the first place, but I'm not sure it would be that significant. Now, what is her risk of a clot during pregnancy? Well, to answer this, we can refer to the table from the practice bulletin that we looked at in video 1. We can see here the risk is small, less than 1%. Perhaps it might be somewhat greater with the patient's sister having a clot, but again, the absolute risk is small. I would not anticoagulate this patient. Now, what do the chest guidelines say? As we discussed in video 1, this is a nice reference and I would encourage you to refer to the chest guidelines on occasion. Now this is right from the guidelines and it recommends antepartum surveillance and postpartum prophylaxis. As I just said, I tend not to anticoagulate at all. The chest recommendations, as you see here, suggest no anticoagulation in the antepartum period, but prophylaxis for 6 weeks postpartum. And I think you can go either way with this one. Now, finally, what are the risks of anticoagulation versus the benefits? If we looked at the risks versus benefits, the risks of anticoagulation with about a 3% risk of bleeding likely outweigh the risk of a clot. Now, ultimately, it is the patient's decision, but after counseling, most are not interested in anticoagulation, and as I've stated, I support that. Of course, I have a low threshold to order lower extremity Dopplers if I have even a little bit of a suspicion of a deep vein thrombosis. Now I'm going to stop here. For video 3, we will look at dosing, what to do postpartum, and how to plan for labor. I will also discuss not obtaining a thrombophilia workup when it won't have any impact on management. Thanks for your attention, and I will see you for video 3.